So, good evening, all. And first of all, I thank the organizers for giving me an opportunity to present. I think, sorry, sharing the screen. So, today our topic is about polycythemia vera and homeopathy. So, before understanding polycythemia vera, just as let us briefly go through the RBC, its nature, and also some of the physiology classes. So, first of all, I thank God Almighty, my beloved parents, my respected teachers of SKHMC, and my humble pranams to our beloved master, Samuel Haniman. So, as always, a student of homeopathy in the past, present, and in the future. So, what are red blood cells? I think the slide is also moving. So,
Ma'am, sorry to interrupt, ma'am. Mohit
okay,
sir, kindly check about the slide, sir. Fourth slide is going on, sir. Fourth slide, sir. Ma'am, kindly tell us when to change the slide, ma'am, so that it will be easy for us. Okay, ma'am.
okay, okay.
Shall we change the slide, ma'am? No.
Ma'am, it is not visible to me. What to do?
It is not visible to you, ma'am.
Oh, yes, yes, ma'am, yes, ma'am.
It is visible
So,
to you, ma'am.
the next slide, please. So, ma'am, next slide. What are red blood cells? Okay. So, what are red blood cells? Thus, we all know that this is one of the important component of our blood. Okay. So, next slide. We can see the picture from here. We can understand the red blood cells, the color, the size, the shape, and what are the main functions that we are going to say. So red blood cells are also known as erythrocytes or RBC, and they are a type of red blood cell. They are a type of blood cells that mainly help in the transport of oxygen and carbon dioxide throughout the body. So this is the main slide, please. So the main function is to carry oxygen from lungs to the body and return of the carbon dioxide to the lungs to be exhaled. This is the simple function. This is said to be simple, but it is one of the key function of the red blood cells. So from the figure we can understand the structure of RBC. So RBC have a typical appearance. It has a biconcave disc-like structure in appearance. So they are small and they are about 6 micrometer in diameter. It has a biconcave shape and they lack nucleus. Okay, they does not have any nucleus, so that which allows them to store more hemoglobin. Hemoglobin is a protein that binds to oxygen. Next slide, please. Next slide. This is the function. This is a function to carry out the oxygen to the body and return of the carbon dioxide. Next slide, please. Next is the structure. Next slide. So next slide. Then the production. So we all know that RBCs are produced from the bone marrow and the lifespan is about 120 days. So significance. So red cells are most common type. It is about 40 to 45 percentage. We are having the red blood cells, and it is one of the important component of transfused blood product. Okay. Next slide. Next slide. So from where red blood cells are produced? Red blood cells are produced from the bone marrow and they are released to the circulation by this a complex process of erythropoiesis. Okay, we have studied from the physiology classes there are complex mechanism behind the formation of RBC. It is known as erythropoiesis and it is a detailed step and just there's no need to go through all this because say lack of due to that lack of time. Okay, so why they are looking red? Because of the component of hemoglobin. Next slide, please. So shape we have say it has a biconcave shape and size. The RBC has only 6 micrometer in diameter. And these are the basic things what we say about RBC. So RBC is one of the very important component of the blood and it has a biconcave disc-like structure. It has no nuclei and it is produced from the bone marrow. It is red in color because of the presence of hemoglobin and the typical function of RBC is it carries oxygen to different parts of the body and also release carbon dioxide back to the lungs to be exhaled. So these are the main important commonly knowing things about RBC. Next slide, please. Next, some facts about RBC. So there are about 150 billion. So this slide is over, ma'am. There are about 150 billion red blood cells in 1 ounce of blood, and about blood. Slide number 6. So the human body manufactures about 17 million red blood cells per second. Okay, there are 17 million red blood cells are produced per second. If stress, it produces to up to 7 times. So when we are under stress, the amount of RBC produced from the body rises to 7 times more. So next, the 18th slide. What makes RBC unique? Okay, what makes RBC unique? There are many factors that makes RBC unique and distinct from other blood components. First one is they are having no nuclei so that they are allowing more room for the hemoglobin. Next one is they are having a unique biconcave size. Okay, biconcave shape like that. And they also have no nuclei. As a consequence of having no nuclei, they can easily pass through the small vessels of the small blood vessels. Ma'am, next slide, please. So these are the facts that we have discussed. Next slide, please. Next slide. Next slide. Slide number 20. Ma'am, next slide, please. So we are directly going to polycythemia vera. Okay. So polycythemia vera is a typical condition and it is a one of the rare condition. So from the picture, you can see that this is the normal blood smear and also the blood smear in case of polycythemia. Now next slide. So in polycythemia, we can see increased number of red blood cells. From the figure itself, it is known that the number of red blood cells will be more. So polycythemia vera is characterized by myeloproliferative neoplastic disorder, which involves in the uncontrolled red cell production, which result in elevated red cell blood mass. Okay, there is an uncontrolled production of the red cell in the body, thereby there occurs a increase in red cell mass. This is the simple pathology behind the polycythemia. So next slide, please. So there are mainly two types of polycythemia. First one is the relative polycythemia and next one is the absolute polycythemia. In relative polycythemia, what happens is that the plasma volume will be decreasing. Okay, there will be decreased number of plasma volume and there will be increased number of RBC and other components. This is the relative polycythemia. Next one is the absolute polycythemia. It is of two types, that is primary and secondary. Under primary, there occurs a decrease in erythropoietin level. So when there occurs a decrease in erythropoietin as a consequence of erythropoietin receptor mutation, it ultimately lead to the primary polycythemia vera. The second cause, first one is the secondary mainly due to the increased erythropoietin as a consequence of compensatory mechanism. Okay, in compensatory mechanism in response to some hypoxia or COPD or any high altitude. In high altitude cases, the carbon dioxide in the body will be more and it will trigger the erythropoietin release. Next, increased androgen are also responsible for increased erythropoietin. That is why males are having more hemoglobin and more red blood cells as compared to females. Next, secondary due to any abnormal conditions, that's any erythropoietin secreting like tumor or any renal cell carcinoma or any hepatocell carcinoma or hemangioblastoma, pheochromocytoma, like that conditions. Okay. Polycythemia mainly there occurs it is a one of the neoplastic disorder of the myeloproliferative system. Mainly there occurs the increased red cell mass and the red cell volume. These are two types, namely primary and these are two types, namely relative and absolute. Under relative, there will be decreased plasma volume and increased hemoglobin concentration. Then under absolute, it is of two types, that is a primary and a secondary. In primary, there will be decreased erythropoietin receptor and any erythropoietin receptor mutation. And in secondary, there will be two mechanisms, mainly the compensatory mechanism, which occurs due to decreased oxygen in the body or increased carbon dioxide in the body and abnormal tumor secreting factors like renal cell carcinoma and hepatocellular carcinoma. So, pathophysiology, next slide please. In patients with polycythemia vera, the bone marrow contains normal stem cell along with the abnormal clonal stem cells, okay, which has action on suppressing the normal cell growth and maturation. So here normal cell also present, also abnormal cell is present. Now next slide please. So from this figure you can understand there is in polycythemia vera there is a increased level of blood cell level. Okay, blood cell level will be increased because of the overproduction of the blood cell from the bone marrow. Madam, next slide please. Slide number 25. So next, JAK2G mutation. So polycythemia is also said to be a genetic disorder. Okay, the gene. So there are many genetic disorders available, but in polycythemia, the gene mutation is JAK2 gene. Okay, a gene that makes a protein that sends signal in the cells to promote cell growth and helps in control the number of red blood cells, white blood cells, and platelets in the bone marrow. So next, the JAK2 gene mainly help in controlling the blood production, mainly or the RBCs, WBCs, and platelets. So the full form is Janus kinase 2 gene. Madam, slide 27. JAK2 gene, that is Janus kinase 2 gene. So mainly the main pathophysiology behind this is that JK2 kinase mutation, where a valin to phenyl alanine substitution occurs at the C17 position of JK2 gene. Slide number 28. Just note the JAK2 gene is very important in case of polycythemia, and here the mutation, that is a valin to phenyl alanine substitution, occurs at the 617 position of the JAK2 gene. Okay, this is the location, typical location of polycythemia. So this is the picture. Next slide, please. So this is the picture of the polycythemia, that there occurs a mutation in case of polycythemia, that is the JAK2 gene. Slide number 29. Next slide, please. Next slide, please. So next slide. Polycythemia there, and you can see the JK2 gene location on the next slide. Next slide, please. Next slide. Okay. So next slide, we are now dealing with the symptoms of polycythemia. Okay. Normally, no patients will directly come to you while saying that they are having polycythemia. Okay. When a patient is been accidentally diagnosed with the polycythemia, because when we are testing for a blood pressure, sometimes the hemoglobin level will be more, and the peripheral blood smear also shows polycythemic features. In that case, we can thoroughly say that the patient is having polycythemia. So there are many symptoms of polycythemia, and the symptoms vary from person to person. So, next slide, please. The symptoms. So, there are many symptoms, but some symptoms are not noticed, and some symptoms include headache, dizziness, fatigue, and blurred vision. Next slide, please. So, the main symptoms include slide number 32. The main symptoms include headache, dizziness, fatigue, tinnitus, vision changes, insomnia, claudication, aquagenic pruritus, gastritis, and early satiety. So these are the main symptoms, that is headache, dizziness, fatigue, tinnitus, vision changes, insomnia, claudication, aquagenic pruritus, gastritis, and early satiety. So erythromelalgia means there will be red spot and the reddish appearance. Then pruritus will be present, hyperviscosity will be seen, and the hypermetabolism will be there. The face will be having a plethoric appearance, and the spleen will be raised. Next slide, please. So enlarged spleen is one of the important characteristics of polycythemia vera. So we know that the spleen is known as the graveyard of RBC. As the RBC production increases, the destruction of RBCs occurs after 120 days. And increased production of RBC, there will be increased destruction of RBC. Hyperfunction of the spleen will be there. There occurs splenomegaly in case of polycythemia rubra vera. So bleeding tendency will be there. There will be unusual bleeding such as nosebleed or gum bleed. Then will be painful swelling of the on of the joint of the body, and shortness of breath will be there. So madam, kindly move to slide number 38. Slide number 38. So according to different systems of the body, these are the main symptoms. On central nervous system, for polycythemia, we have fatigue, headache, and dizziness. On the peripheral nervous system, we have paresthesia and weakness. On the thoracic region, we have chest pain and shortness of breath. On the gastrointestinal system, the main symptoms include abdominal pain, history of recurrent peptic ulcer disease, recurrent peptic ulcer disease, gastroduodenal irritation, and early satiety. On the skin and the musculoskeletal system, the changes include myalgia, erythromyalgia, ruddy faces. On vision, we have vision loss or blurred vision. The psychiatric symptoms include depression or depersonalization and slow meditation. These are the main symptoms of polycythemia upon the location. So previous slide, the polycythemic smear we can see, and this slide the complications and the causes. So there are many complications as a consequence of polycythemia. So first one is thrombosis. Thrombosis mainly occurs due to elevated hematocrit. Okay, hematocrit. The previous slide. Thrombosis. Thrombosis occurs due to elevated hematocrit. Next, hemorrhage. Hemorrhage occurs as a consequence of increased platelet dysfunction. And hematomegaly or splenomegaly occurs due to the increased production or the extramedullary production of hematopoiesis. Next is aquagenic pruritus. Aquagenic pruritus mainly occurs due to the inflammatory mediators of the elevated hematocrit. Next, hyperuricemia, gout, and kidney stone. It mainly occurs due to increased cell turnover, and erythromelalgia or visual loss occurs due to thrombocytopenia or platelet dysfunction. Next, myelofibrosis occurs due to the reaction to the neoplastic cone, and acute leukemia occurs due to the clonal evolution or some many mutation. So next is the allopathic treatment. So whenever a person with a polycythemia goes to a modern school of treatment of the so-called allopathic treatment, there are some options available. Okay, many options are available. First one is phlebotomy, that is the bloodletting technique. This was the technique used by the old school physicians during our master's time. Okay, from that time, our master was very sad about the conventional treatment, and uh, Master Raman started a new system of the treatment. Okay. For the allopathic treatment, they are using phlebotomy or bloodletting. Ma'am, slide number 41. Next, medications. Medications, they are using some myelosuppressive medications. Myelosuppressive medications include antihistamines, aspirin, etc. Ma'am, slide number 41. Next, chemotherapy. These are the main three management of polycythemia by an allopathic physician. These are the symptoms of polycythemia that we already said. The types also we have said. Next, how to diagnose a case of polycythemia. So whenever a patient is coming to us with polycythemia, so how can we diagnose? First, most important thing is the CBC, the complete blood picture we can look for, and there we can see elevated hemoglobin level along with the elevated blood parameters. So first one is the CBC, routine blood checkup, check for the RBC, WBC, and then platelet. Next, look for the peripheral smear, and next bone marrow test. A healthy health provider also do bone marrow test by the aspiration of the content from this abnormal cells. Next, hematocrit. Hematocrit means measuring the percentage of red blood cells in the body, and here in case of polycythemia, the hematocrit level will be raised. Next, one of the most important thing is the erythropoietin test. Okay, this test measure the level of erythropoietin. So erythropoietin, it is one of the important hormone that act as a stimulant for the production of RBC. So in polycythemia vera, erythropoietin level will be low. So the normal range of the erythropoietin will be 2.6 to 18.5 milliunits per milliliter. Okay, this is important. 2.6 to 18.5 milliunits per milliliter. So next important is the genetic test that we already said. Genetic test JAK2 gene to see that any mutation is there. So in 95% of cases, JK2 gene mutation will be there. So pathogenesis, when mutation occurs, okay, when mutation occurs on the JK2 gene, so there will be consecutive activation of the JK2 gene, and when the JK2 gene level will be increased, it sharply lowers the dependence of hematopoietic stem cells on the growth factors. So JK2 gene signaling pathway has a problem. There occurs increased proliferation and differentiation of hematopoietic progeny. Okay, when occurs a problem with the JK2 gene, there will be increased proliferation of the cells. So it can lead to granulocytes and platelets. So in most clinical cases, the symptoms may be related to an absolute increase in cell mass. So we have said that the investigations of polycythemia, first one is the CBC, complete blood count. You can see hemoglobin, blood hemoglobin, MCB, MCHC, and the other blood parameters. Next, check for the peripheral smear. Next, bone marrow test is to be done. Next, check for the hematocrit, the percentage of the measuring substance in the percentage of the red blood cells in the blood, and next, erythropoietin level. The normal erythropoietin level in the body is about 2.6 to 18.5, and check for the erythropoietin level. And next one is the genetic test, mainly JK2 gene. So main pathogenesis is the mutation of the JK2 gene. So diet and regimen. Next is the diet and regimen. So before properly diagnosing this as a case of polycythemia, first of all, ask the patient to ask the patient to do the routine blood checkup. Okay, at least once in 3 weeks. In the diet, next slide please. Slide number 56. So things to avoid and things to eat in case of polycythemia. Sometimes there occurs a false positive result because of the some case of diet. Okay, the patient is having increased amount of alcohol consumption, excess food, or there is a deep fried food production, etc. That will lead to increased amount of polycythemia vera in our body. So slide number 57, foods to eat. So what are the foods we can eat in case of polycythemia? Mainly calcium rich foods are very much important. So calcium rich food as a milk and milk products, most of the milk and milk products, vitamin D foods or vitamin D supplement, and has to drink water daily. Then lean protein. Advice to take lean protein, fruits, vegetables, whole grains and nuts. These all are to be taken. That is the calcium rich foods, vitamin D supplements, lean protein, food, vegetables, whole grains and the nuts. So food to avoid. Food to avoid include oxalate containing foods such as beans, berries, leaf, and purine containing foods such as alcohol, meat, seafood, and avoid excess sugar, high fat, processed food, and a deep fried food. So, next is a case report. Say 28-year-old male who came to the OPD on 9/9/2021 following complaints of polycythemia, back pain, and a pain in left hip. So, there is reddish pimple-like eruptions on the lower extremity, heel pain, dandruff, and a graying of hair, along with the sleeplessness, hypertension, and anxiety. So the patient was under treatment from allopathy before 1 year, and they used to draw 500 ml of blood every 3 weeks, and also allopathic medications for anti-hypertension and flaccid. So this was the blood report on 23rd May 2021, and HB is about 17.4, and hemoglobin level is about 17.4, and the peripheral smear shows polycythemia. So past history of back pain, allopathic medication. Personally, he's studying and had studied diploma engineering, but could not complete. But he is now trying to get a job. Appetite diminished, thirst good, sleep reduced to regular, and thereafter the twinning of hair in the upper part of the body, that is the face and head. So the main symptoms for analysis include mind, anxiety, suicidal disposition, anger, concentration deficit, dandruff, head, gray hair, stomach appetite diminished, sleeplessness, anxiety from stomach desire, cold food, perspiration problems, hemorrhoids, anxiety, orgasm of lip interruptions, failure. So the medicines cover was slide number 68. Please, ma'am, slide number 68. So the medicine scheme was phosphorus 30 bar 12, lyco 30 bar 12, sulfur 28, 9 bar 13, natrium 28 bar 12. So this was the medicine scheme. Next slide number 68. Slide number 68. Then
Moise sir, kindly change to 68, sir. You have kept 61 number slide.
68. So the medicine given was 68. So the medicine, one of the important medicine for polycythemia is phosphorus, and the medicine given on 23rd May 2021, hemoglobin was about 17.4, total count 88,400, 88,800. So after proper case taking, homeopathic medicine was given. Slide number 71. So phosphorus was given. Phosphorus 0 bar 3 is given. Single dose once in 2 weeks along with the BG. 333. The treatment was done from 9/9/2021 to 30/9/2022, and total 26 dose of phosphorus was given. And slide number 71, please. 72, please. So this was the blood picture. The hemoglobin level was about 72 slide, 70 slide. Hemoglobin was about 17.4. The next slide, after treatment, the hemoglobin was about 15.1. Then before treatment, it shows polycythemic smear to rule out the cause of polycythemia. And this is the after treatment, the smear shows normal. So this is the latest lab report. So informed consent of the patient was taken. Homeopathic medicine used to be very much valuable in case of polycythemia. And these are the references. And I thank each and everyone for giving me an opportunity to present. Thank you all.
Thank you, ma'am. Thank you so much for the wonderful session. Respected participants, the session is open for question and answer. If you have any questions, kindly put it in the chat box. Ma'am, what are the major investigations we can put it out for this, ma'am? Polycythemia vera.
Madam, the main investigations first we have to go through the CBC, that is a complete blood picture, that is complete blood count. Here it starts with the hemoglobin and also the blood parameters like MCV, MCHC. It ought to be looked for. And next we have to look for the blood picture, that is a peripheral smear. The peripheral
Mm.
smear is one of the important component to find the what type of blood picture we are having. It is one of the important parameter. Next one is the bone marrow test to check for the aspiration biopsy like that. Next, most important thing is the erythropoietin test, which is done in erythropoietin test to find the amount of hemoglobin. Next, is genetic test, mainly check for the JK2 gene mutation. So these are the main investigations.
Sure, ma'am. Any other questions from the participant? They can put it in the chat box. I hope they have understood the topic, it seems, ma'am. And